مدرس الإشعة التشخيصية. thank you very much for both of you and the talk بعنوان the path to expertise cochlear implant imaging with interactive cases.
Hello everyone, many thanks for your attendance today. We will talk about the path to expertise cochlear implant imaging. I'll discuss briefly the cochlear and related structure anatomical overview, the preoperative radiological assessment of cochlear implants, normal cochlear and vestibular structures, cochlear and vestibular malformations, and the cochlear nerve radiological anatomy and malformations. One of the commonest congenital sensory abnormality is the sensorineural hearing loss, affecting about 2 to 3 per 1,000 live births. Sensorineural hearing loss can significantly affect the lives of these patients as it hinders both the child's social and speech development. The increase of cochlear implants should be attributed in parts to the innovative diagnostic radiological procedures. Those procedures can help in the preoperative, intraoperative, and postoperative assessment. Here is a simple diagram explaining the inner ear. It simply consists of the cochlea, vestibule, semicircular canal, and the nerve supply to each of them. The human cochlea is a snail-shaped, multi-compartmental fluid-filled bony cavity surrounded by compact bone. It lies anterior and horizontal in front of the vestibule. Its base is situated posteromedial to the apex, and it has a central axis called the modulus, through which it forms around it 2.5 to 2 3/4 turn. The inner cochlea is further divided into 3 compartments: scala vestibuli, the upper one, scala tympani, the lower one, and in between the scala media, through which the inner nerve cells are situated. The main target for the cochlear implant is to insert the cochlear electrode inside the scala tympani. In this position, as you can see here, it's near the nerve fibers, so it can easily stimulate those cells and send the impulse to the brain. The radiological assessment for the cochlear implant should include a preoperative assessment, intraoperative assessment, and postoperative assessment. We'll talk today in this part of the session about the preoperative one. The preoperative assessment should help the surgeon with the proper patient selection, the proper selection of the type of cochlear implant and the surgical technique to be used. It should be able to identify clearly the anatomical structures and the absolute contraindications. The preoperative protocol should include both high-resolution CT and MRI. And recently, this high-resolution CT is replaced in many centers worldwide with the CBCT, what's called cone beam CT. Here is the usual protocol we use in the high-resolution CT, and the initial data are then reconstructed at 0.1 millimeter intervals. This is the usual used one. And the CBCT, which is a slightly different type of imaging, we image each ear separately with a rotation of this machine around the patient from 180 to 360 degrees. The scan parameters is also different from the CT. Important reformat concerning the cochlear implant is the cochlear view reformat and the mid-modular view. This is the cochlear view, and this is the mid-modular view. In the cochlear view, we should see the cochlea, the basal turn of the cochlea, the round window, the vestibule, superior semicircular canal, lateral semicircular canal, and the oval window. And the mid-modular view is very useful in visualizing the internal structure of the cochlea. As you can see here, the second turn of the cochlea, and here's the modulus, and here's the apical turn. And here's the bony canal for the cochlear nerve. The MRI is a complementary tool for the CT. Both are useful. We need both together with each other. The MRI, the most important sequence is the thin section heavy T2 weighted image, which is very thin, 0.4 to 0.7 millimeters. This is the best sequence to visualize the fluid-filled spaces of the membranous labyrinth and the 8th cranial nerve. Also, what is very important is the oblique parasagittal view, which is perpendicular to the nerves in the interauditory canal. We'll discuss it later in this section of the lecture. And then we can have map images that visualize the cochlea. And so not to forget, we have to look to the whole brain in the T2 sequence in the axial plane. This is very essential also. So the preoperative analysis should include the cochlear and vestibular system, cochlear nerve assessment, middle ear and mastoid ill-shaped pathologies, important anatomical variants, and any other pathology in the brain. We'll start with the cochlear and vestibular system. Here's a normal temporal bone, axial view. We'll go from up down. Here's the superior semicircular canal, lateral semicircular canal, posterior semicircular canal, and here all are connected with a vestibule. Here's the internal auditory canal, cochlear nerve, canal here. As we all know that the CT, we can't see the nerve, but we see the canal through which the nerve go. And here's the basal turn of the cochlea with the round window. So this is the basal turn of the cochlea, second turn, and apical turn. What we see here is the upper part of the auditory canal, giving the facial and the superior vestibular nerve canal, and here the cochlear nerve and the inferior vestibular. This is just for orientation. We'll go then with the cochlear and vestibular malformation. This will be a brief introduction to the interactive session after this part. We start with the Laprecine aplesia. The Laprecine aplesia is a complete absence of the differentiated inner ear cells. The middle and the external auditory canal are usually normal. This is an example. Here you can see the ossicles, external auditory canal are present, but we will not see the inner ear. It's not present. Second is the rudimentary otocyst. This is also a severe deformity. There is a tiny ovoid or rounded cavity seen inside the otic capsule, and the internal auditory canal is usually absent, as you can see here. This deformity is between the common cavity and the Laprecine aplesia. Cochlear aplesia, complete absence of the cochlea. Dense otic capsule is seen at the anatomical site of the cochlea, and the cochlear nerve is also absent. As you can see here, here is the site of the cochlea. There is no cochlea, dense otic capsule, absent vestibular aqueduct, and dysplastic vestibule. In this type of deformity, this cochlear aplesia, we can have normal vestibule or dysplastic vestibule. Here's another case, no cochlea. There is vestibule, slightly dysplastic, semicircular canal dysplastic. Internal auditory canal is present, but there is no cochlea. So this is cochlear aplesia. Common cavity. In this deformity, the cochlea and the vestibule are merged together, forming one cavity with no internal structure. As we can see here, here the cochlea, vestibule forming one large cavity. And there is dysplastic semicircular canals, superior and lateral. Cochlear hypoplasia. Cochlear hypoplasia, simply, this is a small cochlea. So what is this? There are 4 types of this cochlear hypoplasia. Type 1, type 2, type 3, and type 4. Type 1, this is a bud-like cochlea, just small cysts arising from the internal auditory canal with no features. So what's type 2? It's also a small cochlea, but having the external appearance of a cochlea. But it's also small in size and hypoplastic. Type 3 is a cochlea that is short, less than 2 turns. As you can see here, it has modulus and have the shape of the cochlea, but it's small. And type 4, it's a cochlea with hypoplastic middle and apical turn. The basal turn is okay, but the apical turn and the middle turn are small, are hypoplastic. Here's type 1, just bud-like structure connected to internal auditory canal. Here's cystic hypoplastic cochlea, having slightly the shape of the cochlea from the external appearance, but it's also small. Here's a short cochlea, less than 2 turns. And here's slightly normal basal turn, but the apical turn and the middle turn are small hypoplastic cysts. Incomplete partition. It's also classified into 3 parts, type 1, type 2, type 3. What is the difference between incomplete partition and hypoplasia? That the hypoplasia, the cochlea is small. Like any structure, hypoplastic, it's small. But the incomplete partition, the cochlea, the external features of the cochlea are similar to the normal cochlea, but it's not normal. The internal structure is not normal. Here, in type 1, we have what's called cystic cochleovestibular malformation. The cochlea is in the place of the cochlea, but it's just cyst, no internal structure, no modulus, no interscaleral septum, and also the vestibule is dysplastic. They form what we call number 8 shape. Type 2, we have cystic, featureless middle on apical turn, but the basal turn is okay. This is different from Mondini malformation. Mondini malformation is type 2, incomplete partition, but it should include 2 additional findings. Enlarged vestibular aqueducts, this will be explained in the interactive sessions, and mildly dilated vestibule. Then we can call this Mondini malformation. Type 3 is introduced lately. This was not in the past. This is just normal cochlea from the external appearance also, but there is no modulus, no interscalar septum, and there is a wide connection with the internal auditory canal, as you can see here in the CT and in the MRI. We also have to look for pathologies. If there is no congenital anomaly, there can be another pathology that causes sensory hearing loss in this patient. For example, labyrinthitis ossificans after meningitis, post-meningitic labyrinthitis ossificans. As you can see here, the basal turn of the cochlea, there is ossification starting in it. And in adults, we can see cases with otosclerosis also presenting with sensory neural hearing loss. Then we have to go to the cochlear nerve assessment. The cochlear nerve canal and the internal auditory canal, as we have seen in the CT before in the previous slides, here is the internal auditory canal giving the cochlear nerve canal and the inferior vestibular nerve canal here. And we have said that it's very important to have the parasagittal view in the MRI. Why? Because this gives us the 4 nerves in the internal auditory canal. Very, very, very interesting part to know where each part is it. In the upper anterior part is the facial nerve, inferiorly cochlear nerve, posteriorly superior and inferior vestibular nerve branches, superior vestibular nerve, inferior vestibular nerve. Here is the facial, cochlear, superior vestibular, and inferior vestibular. The cochlear nerve should be equal to the facial nerve diameter or slightly larger. If it's smaller, then it is hypoplastic. If it's not present, then it is aplastic. Also, we can assess the cochlear nerve in the intracisternal part and the intracanalicular part in the heavy T2 images, as you can see here and here. So here's an example of a vestibulocochlear nerve agenesia. In the CT, we can see that the internal auditory canal is narrow, here in the axial and here in the coronal. What is suggestive of vestibulocochlear nerve agenesia is an internal auditory canal less than 2.5 millimeter in the mid part. If we measure here, this will give us a diameter less than 2.5 millimeter. And if we have the MRI of this case, we will find also that it is a narrowed internal auditory canal, and we will not find any vestibulocochlear nerve. Here's another case with cochlear nerve deficiency. As we see here, the previously shown cochlear nerve canal is not present here. It's closed with bone. So there is absence of cochlear nerve canal in CT and marked thickening also of the modulus. Here is another case. We can see here the cochlear nerve entering the modulus on the right and the left side, but on the right side there is no cochlear nerve. And if you get to the parasagittal view, we can see only 3 nerves: facial, anterior, above, and the superior and the inferior vestibular nerve posteriorly. Then we have to look for middle ear and mastoid ear cell pathologies. Okay, this is not part of the sensory hearing loss pathology, but the surgeon enters to the inner ear through the middle ear. So if there is infection, if there's mastoiditis, if there is any fluid in this part, you have to report it because the surgeon will need this information. Here's an example of mastoiditis in a case for preoperative assessment for cochlear implant. Also, we have to report important anatomical variants. For example, prominent or dehiscent jugular bulb, as in this case, or any facial canal dehiscent or apparent carotid artery. This is also very important to report in these cases because this will affect the surgical procedure and how they will enter. The last thing to report is any pathology in the brain that can cause this sensory hearing loss, like schwannoma, cerebropontine angle schwannoma, brainstem ischemia with cochlear nucleus injury, or in cases with subarachnoid hemorrhage, the secondary hemosiderosis that affect those brains. Thank you. This was just a brief introduction to what we will have now. Professor Dr. Togan about the interactive
بشكرك يا
sessions.
دكتورة رانيا جدا، برافو عليكي. الحتة بتاعت الكوكليال والفيستيبولار سيستم it's really difficult. أنا